let's move on, because it's linked to this to the fourth question. What can trust do to improve the voice and status of the nurse in multi-professional working? It wasn't just about nursing per se.
Hi, my name is Barry Keithley. I'm Clinical Fellow to St Ruth's Keogh and also happen to be a junior doctor. We raised a number of points in this area. The first was really addressing the sort of voice and status of the nurse, talking about telling good stories and supporting nurses by getting the executive board and senior managers to really share stories of good experiences with other teams, and to use this sort of have a collaborative celebration really of good things that are happening, so that nurses felt valued in the good things that they did achieve. We also talked about the other little things that do make a difference, like thanking them for their time and for the good things that they do. But also touched on the other issue, which is actually allowing them to care, and perhaps going back to Gordon's previous point about a lack of productivity and having so much of your time spent doing things that don't really contribute to patient outcome, and maybe freeing up nurses to have the opportunity to do things and concentrate really on the tasks that they want to get involved in, which are really to do with patient care, rather than perhaps forms and other things that aren't so aligned in that way. We also mentioned the code of conduct, and nurses are judged by this, it's called code of conduct, it's how they're held accountable. But they should also feel empowered to use that code of conduct to refuse to do things that are beyond the remit of what they should be expected to do, particularly when they're working in an environment that puts them under undue stress. Another issue that was raised is also the organisation of the ward round, and again, coming back to Gordon's point about efficiency. Having, for example, using the example of the ward round as an example, having a central focal point of communication where a nurse is present on the ward round and the consultant medical team goes around and speaks to each patient. At the bedside of each patient there is a nurse who not only acts as the advocate for the patient, but also is able to communicate information that she, and only she knows, about the last 24 hours of the patient's care is very important. And it still seems strange that in this day and age that so many ward rounds do occur, and certainly my experience as a junior doctor is that several ward rounds occur without any nurse present at all. And that's a really, really important aspect, because getting that communication right at the start of the day dictates the work patterns for both the junior doctors and the nurses and the other ward staff for the rest of the day, and it saves up a lot of time to spend in terms of inefficiency chasing up junior doctors to do things that were already discussed in the ward round, and so many vice versa, and junior doctors asking nurses to do things that were already discussed.
Why do you think that does happen? It happens in some places and not others. Is it to do with the way that doctors see nurses?
I think doctors are to be blamed in some respects, but I don't think there's a universal answer to that question. I think in some areas, and certainly some trusts that I've worked at that do this very well, there's really been a very powerful ward sister figure that's pushed herself onto the scene and said, I am going to be present on the ward round, and that has really fed through to the doctors as well, such that, certainly in one of the trusts I worked at, it got to the stage where if the ward sister wasn't there, we felt that we couldn't do the ward round, and so we sort of turned around and go and find the ward sister. But that kind of subconscious level of leadership really sort of values the role of the nurse, and that's something that we need to work towards. And the other thing, the last point really to make is a point about collaborative planning, and giving nurses an opportunity to sit down at a table with junior doctors, with managers, and really discuss issues that they feel they want to address. And there are instances of that happening across the NHS and in local, regional places, but it hasn't really been taken up at a national level yet.
Any comments on that? I saw some grins coming across the tables. From your experience, is that expectation that nurses should be there on ward round, is that basic, or is that something that's still a bit unusual?
We're obviously children into each other, but not speaking out loud. I mean, it's an absolute basic requirement. I think that the nurses amongst us would be saying, well, it would be nice to see the doctors on the ward more often, and it would be nice to have some ownership of the ward. Certainly, and not trying to hark back to days that have gone and probably will never return. But having an identity of a medical team on a ward where it is a team effort and it isn't 6 individual consultants who all happen to be of the same specialty coming in, maybe all together, maybe at different times, but all expecting a nurse to accompany them on the ward round. Some of whom might know the patient, some might not. And that's the difficulty, and I think there's something about having that MDT approach to the ward and having a clinical medical leader for a ward, even if it's a rotational position. It's something that we've introduced where we've had wards with some problems, so that there is a focus of leadership for the doctors as well as the nurses.
What changes did you see, Jill, when you introduced that in your trust?
Somebody that the nurses could go to. Instead of going to 6 or 7 individuals, they could go to one and expect that one individual to go and represent the views of the nurses or for the doctors to come back. It wasn't sort of a unionised approach or anything, it was just very much about an MDT, a focused leadership approach. And it meant that simple things like coordination of ward rounds, issues that nurses maybe wanted to introduce but had to get consensus across the medical workforce, they could go through one individual rather than having 6 different conversations, and it just made life much more productive, much more efficient.
Do you think it improved patient care?
I do, because patients knew the doctors knew the patients, the nurses knew which doctors were in charge, and that we've now got ward-based teams for junior medical staff, so that the nurses know who to speak to on the wards, which doctors are going to be there, when they're going to be there, and it's just much better for relationships and that team working together.
Well, we've heard that theme in other seminars, that a lot of clinicians now work in pseudo teams. They're not really teams, they just happen to be in the same place and not always at the same place. Pete, do you want to comment?
Thank you. Yeah, Peter Carter, Royal College of Nursing. I concur with what Jill's said and what others have said, and the Royal College of Nursing are working closely with the Royal College of Physicians on this, because this is an issue in some hospitals, not in all hospitals. We see the ward round as one of the key interchanges between the patient, other members of the team, the nursing staff and the medical staff in the patient journey. And it's wholly unsatisfactory if nurses are not present at ward rounds. Now, I know there are some logistic difficulties, but many hospitals do it and do it well. We think it should be standard practice, and as I say, it's something that we're working on. Sorry, just one other point. Far too often, nurses are asking patients what was discussed at the ward round, which again leads to confusion, and it leads to a lack of confidence, and reinstating the multidisciplinary approach has got to be the way forward.